transplantation for thrombotic microangiopathy, the challenges. Actually, the aim of my talk is to do our best before saying no. We will not transplant these patients with end-stage renal disease due to thrombotic microangiopathy. I cancel several slides in order to be matched with what Professor Muntasir Zaid presented. My agenda will include a short background, challenges in diagnosis and management, recurrence and its prevention, and lastly, we may conclude in key points. I will start by 3 case presentation just to transfer a message. Case number 1, a 30-year-old man presented with headache, blurred vision, and had no previous medical history. His father had died prematurely at the age of 35, but the patient did not know the cause. On clinical examination, his blood pressure was extremely high, and the fundi showed hypertensive changes. Investigation showed anemia, thrombocytopenia, and red cell fragments in blood film, high creatinine, normal C3 and C4, and normal size kidneys by ultrasound. The question is, what is the most likely underlying diagnosis? I will answer D, atypical hemolytic uremic syndrome. The second case is a 40-year-old man was found unconscious, feverish, and blood pressure 150/80. He has the same triad: anemia, thrombocytopenia, red cell fragments in blood film, C-reactive protein and iron are normal, creatinine modestly elevated, and CT scan of the brain was normal. What is the next appropriate treatment? The answer is B, plasma exchange with fresh frozen plasma replacement. The third case, an 80-year-old man presented with vomiting, fever, diarrhea. He appeared dehydrated, hypotensive, he is anuric, he has anemia, thrombocytopenia, red cell fragments in blood film, C-reactive protein is high, he has hyperkalemia, acidosis, high urea and creatinine. Which of the following treatment should be considered first? Of course, intravenous calcium gluconate, fluid challenge, and if required, hemodialysis. This is to transfer a message that thrombotic microangiopathy can manifest in a diverse range of diseases and characterized by thrombocytopenia, microangiopathic hemolytic anemia, and organ injury, including acute kidney injury. Usually, it is associated with significant morbidity and mortality. So, our challenge here is to diagnose and to manage. And this is an acceptable practical classification of thrombotic microangiopathy as Professor Muntasir Zaid presented. Here we can find that we have a primary, either hereditary or acquired, and secondary and infectious associated. And the message here is that the patient with atypical HUS with genetic background does not present earlier, but present at all stages of life despite the genetic nature of his disease. And one explanation is that it needs a triggering environmental factor such as infection, drug, pregnancy, and that is why we have to observe that the secondary TMA due to pregnancy-associated HELLP syndrome, de novo TMA after solid organ transplantation, and others may have an underlying genetic background. In spite of the genetic screening mentioned by Professor Muntasir, still we have limitations, still we have a paradox because we have a clinical overlap, the diagnostic test is not available, and if available, it takes 3 to 4 weeks, it is expensive and time consuming, and at least 30% of patients do not have currently known mutations, so negative genetic testing even does not rule out atypical HUS. That is why we consider that the diagnosis still rests on the clinical judgment of the physician. Historically, atypical HUS outcomes have been dire, and over 50% of patients will die, have required dialysis, or have developed permanent kidney damage within 1 year of disease presentation. Eculizumab is a humanized monoclonal antibody that inhibits alternative pathway activation by blocking C5. It has been shown to be effective in treating patients with atypical HUS. This algorithm is useful in order to be aware of the different subtypes of thrombotic microangiopathy. When we have a patient with first episode of HUS, we have to rule out several diseases, either infectious related or systemic disease, and we have to rule out ADAMTS13 deficiency. Still, the first line of treatment, as Professor Muntasir said, it is plasma exchange therapy. When we have uncertain diagnosis of primary atypical HUS, then we can proceed to genetic screening, and still first line of treatment is plasma exchange. And we are waiting for response, either plasma resistance or dependence. In this situation, one question will arise. Who should treat it with eculizumab? Any patients? The answer is any patient with a clinical presentation of atypical HUS should be considered as a candidate, either involving native kidney or transplant. The second question is that, do complement investigation impact therapeutic decision? We should have a rapid screening for anti-factor H autoantibodies in order to save the unnecessary use of eculizumab and to give immunosuppression. When we have an unequivocal diagnosis of atypical HUS, then the first line of treatment will be eculizumab. Here, a third important question will arise: for how long should patient with atypical HUS be given eculizumab? Actually, we don't know the answer, but we know that a single dose is inappropriate, and the key issue of optimal treatment duration should be urgently addressed. Recurrence and its prevention. Before the era of eculizumab and with plasma therapy is also available, the risk of death or end-stage renal disease at first episode or within 1 year, the risk of relapse after treatment, or the risk of recurrence after renal transplantation is extremely high. And this is supported by this series in pediatric as well as in adult. That is why the KDIGO recommend risk stratification for recurrence, either high risk, moderate risk, or low risk. And in high risk, as said before, prophylactic eculizumab is the first line of treatment, but in moderate risk, we can use prophylactic eculizumab or plasma exchange, and sometimes it will be left to the decision of the transplant nephrologist. Low risk, there is no need for prophylaxis. Again, to the clinical, the risk of TMA recurrence occur with older age of disease presentation in native kidneys, in higher in cases characterized by more dynamic evolution of TMA leading to end-stage kidney disease, and is higher in living-related donation and in patient treated with calcineurin inhibitor. Although prophylactic eculizumab therapy may prevent recurrent disease, its necessity for all transplant recipients is debated. And before assessing eculizumab, we have to assess its safety. And this 5-year experience from Global Atypical Hemolytic Uremic Syndrome Registry, the enrolled 1,321 patients, either adult or pediatric, again subdivided into ever treated and never treated patients. And they found in this large observational data set covering 5 years of registry enrollment that there is no new safety concern were identified for adult or pediatric, except for more serious infection in pediatric and more deaths in adult, confirming a positive benefit risk profile in a real world setting. And this is a systematic review and meta-analysis assessing the outcome of kidney transplant patient with atypical HUS treated with eculizumab. They have 18 studies, 13 cohort, and 5 case series above 400 patients, and they found that among the patients who received the prophylactic eculizumab, the incidence rate of recurrent TMA after transplantation and graft loss due to TMA were 6.3% and 5.5% respectively. On the other side, those patients who received only eculizumab for treatment of post-transplant atypical HUS recurrence, the incidence rate increased to 22.5%. And these results suggest a possible advantageous role for anti-C5 antibody. However, future prospective studies and clinical trials are needed to evaluate for the efficacy of eculizumab, timing of initiation, duration of prophylaxis, and treatment therapy according to genetic mutation. This is an old schematic representation of transplant option in atypical HUS patients, ranging from single kidney transplantation in membrane cofactor protein mutation, single kidney transplantation combined with plasma exchange, steroid, and or rituximab, whereas when there is anti-common factor H autoantibodies, or combined liver and kidney transplantation in complement factor H and I mutation, which is synthesized in the liver. However, this situation is difficult and is associated with significant mortality, and so the decision should be taken case by case. In C3 and common factor B, single kidney transplantation combined with intensive plasma therapy could be recommended, but eculizumab should be ready for refractory cases. This is an attractive paper. This paper has been carried out in 2 university centers in the Netherlands. They have a case series of 12 females and 5 male patients, and they use no prophylactic eculizumab in spite of having 16 patients stratified as major risk and 1 patient moderate risk, but their treatment protocol aims to lower the risk for recurrence and save the cost of unnecessary eculizumab. They used living kidney donor to eliminate the ischemia reperfusion injury. They used basiliximab prophylaxis, anti-interleukin 2 receptor antagonist, which block T lymphocytes without causing complement-mediated cell lysis. They use low-dose tacrolimus, targeted blood level 4 to 5 microgram per liter in the first months and 5 to 7 thereafter. In order to avoid the potential endothelial injury, they used high-dose MMF 1 gram BD guided by monitoring the area under the curve. They used prednisone and taper to 5 mg at the end of 3 months. Strict blood pressure control was achieved earlier, and they used ACE inhibitor and statin as early as possible in order to eliminate or to reduce the risk of vascular endothelial injury. As you can see here, all patients except 1 high risk for recurrence. Only 1 patient showed relapse after transplantation, and they gave eculizumab treatment with good response, and then discontinued again, and after 3 months relapse occurred again and given again eculizumab with good hematologic remission, but the kidney function started to deteriorate. These data suggest that kidney transplantation with a living donor kidney in atypical HUS may be feasible without eculizumab prophylaxis. Treatment protocol aims to lower the risk for recurrence. However, when this protocol is applied, patients should be monitored closely, and eculizumab should be immediately available in case of recurrence. Interestingly, the authors has 3 patients with living-related donation, which is considered a contraindication for donation, but 2 patients were the genetic screening for these 2 patients was carried out to eliminate the risk of problem after transplantation, and the data for 1 patient is lacking. However, still, an unrelated donor is an acceptable policy. And the editorial commented on this work, and he's agreed and presented some of his experience which is compatible with this report. So we can reach the key points. This is a simple diagnostic algorithm. When we have a microangiopathic hemolytic anemia, thrombocytopenia, organ dysfunction, we can initiate plasma exchange and to test for ADAM-TS13 and Shiga toxin. If ADAM-TS13 is absent, we can treat as TTP. Shiga toxin positive, we can treat as infectious HUS. We have to look for complement amplifying conditions and to treat. If TMA resolve, we can observe. If TMA persists, atypical HUS likely consider eculizumab. We can see here the risk stratification. We should not forget the clinical parameters signifying high risk of recurrence post-transplantation. And the attractive paper there is data suggests that kidney transplantation with a living donor may be feasible without eculizumab prophylaxis. But the non-attractive point is that eculizumab should be ready for use when relapse occurred. Of course, the exceedingly high cost of eculizumab is a strong barrier to its use, and the authors in this paper reported that they saved several $million. It seems in cases of both transplantation relapses, eculizumab treatment should not be discontinued. And I would like to ask if it is the time to have eculizumab in Egypt and to assign a committee or one or two centers to manage such a difficult situation. Thank you for your attention.